No, you were setting up questions that were so difficult. I was thinking about, can I get out of this room without answering them? So that's the case. I'll give you one bottom line of mine, which is that there is no need to expand the budget. We just need to reallocate the budget. We've spent enough in healthcare. There's plenty of sort of room there to do the essentials that are not sort of being done today. Congresswoman Shalala this morning sort of mentioned the Affordable Care Act, which I think is a great example. The Affordable Care Act, according to CBO, is actually saving the federal government money, even though we had this massive expansion in terms of insurance coverage and subsidies and other things as well. And it's not because when we insure people, they start to use services and that reduces their cost of other services. No, the answer is the Affordable Care Act went after areas of waste in healthcare and reduced those. And those are the sources of money to do the good things in terms of expanding coverage, increasing public health activities, et cetera. So that's the model that I think we really need to be thinking about, is reallocation, not sort of just simply sort of thinking about, you know, where are we going to get the extra money that we need because we spend enough sort of in healthcare today. So I didn't mean to start sort of with a bottom line. I was actually going to start by saying I'm surprised to be here, because I feel like my background is very different than the rest of the people, most of the rest of the people in this room, if not all the people in this room. I've spent about 45 years now doing health policy, but I could say that sort of a slight modification to the title of this session might sort of characterize what my life has been. It would be comprehensive health policy without oral health. I spent more than 40 years with paying no attention to oral health, I confess, okay? And I'm only sort of have been redeemed because of the good graces of West Health. And I wanted to tell you a little bit about West Health, since they're responsible for sort of my conversion. West Health consists of a group of organizations, a medical research institute, a policy center, and sort of a foundation that are the result of two incredible people, Gary and Mary West, and their generosity in terms of supporting these organizations with the mission of improving health care to aid seniors by age more successfully sort of in their lives. The West didn't have sort of my myopia about oral health care. West Health also has a dental center. And the dental center came about because West Health was supporting a senior center in downtown San Diego where about 1,200 meals a day are served. And the West volunteer there on a regular basis, and they observed the very poor state of oral health among these low-income seniors using the senior center. And rather than lamenting it and saying, this is awful, they said, we're going to do something about it. And they invested in the development of a dental center within the senior center. And I was there at the beginning watching that senior dental center open, and it was eye-opening in terms of seeing the information that we gathered about the people that were coming to get care, people that had not seen dentists in years, people whose conditions were so complicated and extreme that it took 7, 8, 10, 12, 15 visits before they could sort of be stabilized, so to speak, and move on to sort of ordinary care. So that was incredibly eye-opening sort of for me, and I've been very much engaged sort of in oral health issues since then. The other thing that West is working on, besides the issue of better delivery of services to improve the lives of seniors, we're very focused on the issue of cost. And that's where I come to the conclusion that I indicated sort of when I first started talking, which is we have enough money in the healthcare system. In fact, we have too much money in the healthcare system. It needs to be reallocated because we're not going to get more. We're already crowding out education. We're already crowding out sort of infrastructure sort of investments. We need to spend our money better We cannot count on spending more as we see this aging population growing and as we see sort of needs among the non-elderly sort of as well. So what I'm going to do today is I'm going to talk to you from the perspective sort of a payer. And I have to confess to you, I've never actually been a payer. I have never gotten a check from CMS, a paycheck from CMS, but I was at the GAO, the General Accounting Office, now known as the Governmental Accountability Office. And their job is to sit on CMS's shoulder and observe everything they do, and in some respects, second guess them. So I feel like I've sort of had a lot of sort of inside sort of perspective, even though sort of I have not sort of been on their payroll. I'm going to talk primarily about sort of the issue of medically necessary Medicare coverage, but I also want to talk more somewhat at the end about the broader question of a more comprehensive sort of Medicare benefit. I'll give you the bottom line on medically necessary sort of Medicare coverage. It's going to be a hard sell to a CMS sort of administrator. There's going to be, I think, several kinds of reactions. One is all new things are hard to do, okay? And so there's this question of, do I want to take on something new? Second aspect of it is, you've explained this to me, this seems a little harder than normal. This is above average in terms of a difficulty level. And then the third thing I think they think about, and which you probably may be a bit surprised to, they're going to worry about, can we do this well? This is the consideration that is something that CMS would certainly sort of have within their sort of mindset. I know that's not a message that you wanted to hear, but there is the principle that being forewarned is forearmed, so hopefully you will not sort of be too unkind to the messenger. Okay. Let's talk sort of now about sort of the more of the detail of sort of why CMS is going to react this way. We can start with the premise, and I think it's very easy to accept these premises, that medically necessary dental coverage has positive effects, and there's a clinical basis sort of for this. We can also start with the premise that I've seen sort of legal analysis that says it's also within the scope of the current Medicare statute. Medicare says we will cover medically necessary services, and these types of services can be included. But having accepted those premises, then you have to think about, what am I going to do to try to sort of implement something? And I think there are three things that the CMS administrator is going to be asking. And the first one is, what are the exact services I'm going to cover? The second one is, how and how much am I going to be paying for these services? And the third is going to be, how can I be assured that the services I'm paying for are medically necessary dental services for people actually sort of in need? Those are the three kinds of things that an administrator will be thinking about. And there's probably many more than one definition of sort of medically necessary dental care. But I looked at one, and I'm going to read this to you because I think to me, as an economist, not as a clinician, this is complicated. Medically necessary dental care is treatment that, according to accepted clinical protocols and standards of practice, are considered integral and essential to the management or treatment of a medical condition or for the prevention of medical complications from the direct spread of dental diseases. Maybe that sounds very straightforward, but then the next sentence was, medically adjunctive dental care, while clinically relevant, is not integral to and essential to the treatment or management of medical conditions. I feel like we're in an area where there's latitude. And if you're running a program, latitude is an enemy. So you have to be thinking about sort of, how am I going to establish sort of the coverage criteria sort of for this benefit in a way that it can defend and I'm going to feel sort of comfortable with. Second issue is payment. Medicare has never paid for dental services. Medicare has invested, I would say, well over $100 million, maybe sort of hundreds of millions of dollars in developing the payment systems that they have in place for hospitals, for physicians, for skilled nursing facilities, for home health, for durable medical equipment, et cetera. We're starting from scratch here. And you can maybe say to us, use UCR. Let's take the charges that are being observed, and that'll be fine. If I'm the administrator, I have to ask myself, is that going to be fine? Because we have a history in Medicare where when we began the program, that's exactly what we did. We told sort of the physicians we're going to pay on the basis of your usual customary reasonable charges, and everything's going to be okay. And then we've spent the last 50 years moving away from that. And so there's this question of how am I going to pay, and how do I solve that in an efficient sort of way. The third sort of area is how do I assure that claims that are coming in are appropriate? Are they're for people in need, for the service that they need? Medicare gets almost no information about a service when they pay a claim. They get a diagnosis, and they get what the service is, a procedure code, okay? And we heard earlier today, they're not even going to get a diagnosis from the dental side sort of this situation. They're going to have maybe a medical diagnosis, but they're not going to sort of have a dental diagnosis. And so how do you make a judgment? Is this sort of an appropriate sort of a service, and then I should sort of pay for it? And we could say that, well, we'll just have dentists and physicians submit more information, and that will sort of solve the problem. And if we lived in a world of great interoperability, that would be a simple problem to solve. And I mean, and I think we should all hope that someday in the future we do live in that world, because we would run our programs much better if we did have much more complete information that could flow from not just about one person being seen by one provider, but from all the providers that an individual sees. But we don't live in that world today. So we would be imposing a burden sort of on dentists and potentially and also physicians to coordinate as to what it is and what are the reasons why this service is a medically necessary service. That is potentially going to have an incredibly negative impact on dentists willing to participate, okay? You hear it from the physicians, even though they send in relatively limited information, about the burden of participating in Medicare. Well, as we introduce dentists to the Medicare program, are we going to do it in a way that they're also going to feel this is a burden? Because the other reality is we're probably not going to be talking about large volumes of care. So gearing yourself up to submit some claims for only a limited number of those claims, there's that fixed cost of starting to do the first claim, and then you don't have many more. So that's negative. And then there's the issue of what level are we going to pay for, and so that's going to discourage sort of participation. The other thing is, even if we were successful in terms of asking sort of dentists and or physicians to submit more extensive information, a CMS administrator is going to ask themselves, do I have the capacity to even look at that information? Right now, Medicare receives over well over a billion claims a year. 1% of those claims are ever looked at by anything other than a computer doing a screen. And is this an acceptable procedure code? Is this an acceptable diagnosis? There's a limited number of combinations where they will be disallowed. But for the most part, there's no real review of claims. And it's because CMS is one of the most under-resourced entities probably in the federal government, okay? You can compare CMS sort of to other insurers or to the VA or the DOD, and you ask how much do they spend in terms of processing and administration of their programs or their policies, and it's 2, 3, 4, 5 times as much as CMS sort of has. I did once when I was at GAO, we did a study and we were comparing sort of the resources at CMS to the resources of the National Park Service. And I've got nothing against national parks, but national parks are not running close to $1 trillion program today. And so the question is, when you're spread across a program that's $1 trillion in spending, you know, you really need the resources to do sort of effective oversight. CMS does not have that. I would feel hesitant, in part, to give CMS recommendations about how they could structure review of medically necessary dental claims, because at one point when I was at GAO, a CMS administrator said to me, every time I take one of your recommendations and I try and do it, I have to stop something else. That's the world they live in, and that's the factor that they would take into account. When you approach them about sort of medically necessary dental benefits, they may agree to you that this is a very important thing to do, and then they may start to think in the back of their head, among all the very important things for us to do, where does this fit sort of into that list of priorities? That's a dilemma they face. I didn't want to come here and be just a total naysayer, okay? So I tried to do some homework. I had a number of conversations with Bruce Laddick. I'm sure many of you know him, a former CMS administrator, as well as Dr. Larry Coffey, sort of someone who's been very interested in medically necessary dental services. And what we concluded sort of after these discussions was we needed to think about something where CMS could start small, because that would, one, make them less nervous about inappropriate spending. And we also needed, though, to give them, to start with something where they could learn, okay? Give them some opportunity where there is already more scrutiny, and there is, therefore, there is the potential to learn from having sort of already invested sort of in extra scrutiny. The two ideas was to build more into looking at sort of coverage of dental services for people who are facing certain transplants, because organ procurement costs for transplant patients are an area where CMS pays on the basis of costs. The costs are studied, the costs are audited. You could learn something about sort of what it would took to pay sort of for dental care sort of in that circumstance. The other area was to think about, and this goes to the discussion earlier about value-based payment, was the issue of what's happening with respect to bundles sort of within Medicare. The idea for joint replacements where you need sort of dental clearance to receive a joint, that you try to build, and there would be a task here, but you try to build sort of dental care sort of into the concept of the bundle. You've got a situation sort of where the provider, it has an incentive to be efficient. You're going to learn about utilization, appropriate utilization. You're going to learn something sort of about sort of appropriate sort of payment. I had some hope for a while. I'd heard a lot about, wait a minute, this is just not fair. Medicare does not cover dental services, medically necessary dental services, but they cover medically necessary podiatry services, and the same language virtually in the original Medicare statute is Medicare shall not cover routine foot care, okay? And so I wanted to see what's going on here, what's the model, and is it something that we could think about sort of using as either leverage or sort of a device sort of with respect to dental care. Well, it turns out podiatry care covered by Medicare is incredibly small, all right, which makes it much easier to think about why CMS and Medicare is comfortable with it. Plus, it started, I mean, I have heard from at least one source that it goes way back, maybe even into the 60s. We know for sure it was in the 80s. There's a national coverage decision in 2002. And so it's been there for a long time. Maybe it came in under some circumstances that explain it, but it's been there for a long time. But podiatry compared to dentistry, there's about 15,000 podiatrists in this country, roughly, and I think roughly 200,000 sort of dentists, okay? There's the podiatrists, virtually all of them are participating sort of in Medicare. About 8,000 of them send in a claim sort of in the course of a year. The total spending on those podiatry claims is about $8 million. The claims come in, they're billed at $30. Medicare marks them down to 10. The program pays 8, the beneficiary pays 2. So it's not a lot of money. It's something like less than 1/1000th of a percent of Medicare spending. So that it's not something that's really much on anybody's radar. It's not necessarily a model to think about. And I have to say, sort of when we talk about medically necessary coverage and all the sort of support that you've gotten for it, that actually can be scary. You know, you said earlier we have 85 organizations sort of endorsing this. The question is, what are they thinking about in terms of how big this benefit sort of would end up sort of being? Now, everything I said can be totally irrelevant if the Congress says, do this, okay? It doesn't matter how hard it is, what your other priorities are, et cetera. If the Congress says, do this, it's a new game, all right? It was very interesting this morning to hear Congresswoman Shalala talk about how you might sort of influence the process. I mean, and I think that most of us would probably say that the thing is you go and you get a law passed to say, we're going to do this. And if you remember what she said this morning, she said, essentially, get somebody on the Appropriations Committee at the hearing for either the CMS administrator, or I'm putting some more words into her mouth, and for the CMS administrator or for the secretary to say, why aren't you doing this, okay? And it was interesting because what we normally think of as the committees overseeing Medicare sort of in the Congress, it's the House Ways and Means Committee, the House Energy and Commerce Committee, and the Senate Finance Committee. They are the ones that write the laws that change sort of Medicare. And I think that Congresswoman Shalala, when she was Secretary Shalala, she had personal experience about how important it was to respond to the members of the Appropriations Committee that determines the HHS budget, the CMS budget. So that's potentially sort of good advice to think about in terms of sort of how one sort of moves forward. I think in terms of and this applies to, in some respects, if in talking with congressional members and staffs about either sort of the medically necessary benefit or sort of the more comprehensive coverage, it shouldn't be sold, it shouldn't be sort of based on we're going to save money. And I'm not disputing sort of any of the studies that we've talked about here. I accept that they're all valid. There's an issue, though, in Medicare that is different, okay? We had private insurers, and I looked at some of those studies, okay? The private insurers have a lot more capacity to direct the services that they're paying for. As I've been talking about Medicare, and I'm talking about that 1% review of all their claims, okay, they pay essentially blindly. And so there's this question, and this is the question that CBO will ask. I know they will ask this because they've actually written a report about it. You showed me that some intervention can save money for some individuals, for some groups. Can you demonstrate to me that we're going to limit the benefit to those individuals, those groups? And we've got experience with respect to case management, care coordination, substituting home care for nursing home care, all where we served a bigger population, and so there was a net increase in spending. And that's where CBO sort of will come back and say, this is going to be a problem because we cannot target sort of well enough. This idea of limited resources, again, I think there's a question of, is it really believable? And I was thinking, maybe there's an analogy that helps bring it home. Everybody here, I'm sure, has a smartphone. You're all texting and emailing all the time. Think about doing that with mittens on. That's the way CMS operates. They've got mittens, all right? They are not sort of that adept in terms of, or not, I shouldn't say adept, they're not that capable because of the limitations on resources of being able to be as focused as one needs to be. The other thing I would think that is sort of very important is what we really need, and this comes from the work that I'm doing with West. I really feel it's essential that we do a better job of promoting what demonstrating sort of what the level of unmet need is and what the benefits of meeting those needs are. We're working now trying to do what we can to help enhance the safety net for oral health care, okay? We're doing that now in one of the best economies we've had in a really long time, okay? I'm worried there is going to be another recession. We have to have the evidence together that convinces the policymakers then at the state level that, yes, you have to balance your budget. Yes, you have sort of more restricted resources, but this needs to be sort of a priority. I think the same thing is true at the national level with respect to Medicare. We have to convince the Congress that this needs to be a priority because of the benefits, the unmet need, the impact on an individual's life when we start to sort of meet those needs. All of this is not going to happen overnight. The other things we can be thinking about doing is, how would you design a Medicare benefit? Let's talk about payment policy, because this is an area we happen to be working on at West. Yeah, if we have fees, if you think about sort of this fee-for-service system that we have sort of now, and if we have fees for all the different procedures, is that going to be good enough? And our answer is no, because it turns out that there's big differences in terms of how difficult or time-consuming or costly it is to treat different seniors, okay? And so as a result of that, what we've done is we've been working in California to get modifications to payment for what we call special needs patients. And their special needs are not more complicated dental care. Their special needs are the fact that they've got a medical condition, a behavioral condition, sort of a social condition that complicates their medical treatment. It could be something like they just have great difficulty getting into the dental chair. They have great difficulty staying in the dental chair. They have great difficulty sort of complying sort of with requests in terms of the treatment and that's being received. This is something I think is an example of something that we need to be thinking about is what are going to be good policies. Let's assume we're going to be successful about this. What are going to be the good policies that we want to implement when we are successful? Because if you read congressional laws, they're very general. They will say the secretary shall, and you can fill in after that is go figure this out. And so we want to be in a position that we're ready to give recommendations to the secretary to say this is the way it will be done to be so that it will be more effective. Thanks very much. I'd be happy to answer any questions that you may have.